All right, class, today we start on our acid-base balance. Acid-base balance is looking at arterial blood gases. That is one of our major jobs to do, is to draw the blood gas as well as interpret the results. We are known as the experts of interpretation as well as treatment. Most of the time nurses have maybe a 2 to 4 hour course on interpretation, so they don't really get the deep knowledge that respiratory therapists do, and they just don't practice it because they know they have us to rely on. So we need to be able to interpret them, treat them, and be good at it. That's one of our main pride and joys of being a respiratory therapist, is being good at interpreting blood gases. So we're going to start with the basics today, and then we're going to spend the rest of our time in physiology focused on arterial blood gases. Our objectives for the day are explaining how CO2 is transported. We'll look at acid bases and buffers, and we'll look at how to maintain the pH in the normal range. We'll also look at the PaCO2, the bicarb, and the pH and how they change in each of those conditions listed there. We'll determine how your patient will look like, or how your patient will look with each of these types of acid-base imbalances. We'll treat that patient, and then we'll figure out how the body will compensate for each of those imbalances. Okay, so let's start with the definitions of acid bases and buffers. The important thing to know is that CO2 is transported by the bicarb through a chemical reaction and eliminated in the alveoli. During this chemical reaction, oxygen is released to the tissues. The loading and unloading of CO2 is affected by how much oxygen is bound to your hemoglobin. So just as O2 is affected by the CO2 is affected by the oxygen. So if you have less oxygen in your blood, it leaves more room for the carbon dioxide to settle in. So we have to maintain that balance of oxygen and CO2. Otherwise, we have what's known as the Haldane effect. As the CO2 moves out, the oxygen can move in. So we always want to maintain that ventilation and oxygenation balance. This is a good little cartoonish type picture explaining how the acid base is kept in balance. So the first bubble says, too many H ions make me more acidic. The body works with a very narrow range. Small pH changes alter biologic processes. So the body wants to maintain a pH. I'm going to have you change that bottom graph just a tiny bit. Arterial blood for our purposes will be 7.35 to 7.45. That's where arterial blood gas normals lie. Most diseases can cause an imbalance of our pH system, or our acid-base balance system. An imbalance can cause more problems than the disease itself. So the next bubble says, I am the first to respond to keep the pH in balance and to neutralize the pH, or neutralize the H ions. Then the respiratory system says, well, if Buffy the buffer can't do it, then I will do it. I'll step in and control the CO2. So the lungs control the ventilation part of it. Okay, so if there's increased CO2, the pH is going to be lower. Okay, because there's more H ions available in the blood. So it will drop the pH. There's an inverse relationship there. I want you to keep that in mind. As the CO2 increases, the pH will decrease. The last part is the renal system. I'm slow but dependable. I control the bicarb to neutralize it. So the higher the bicarb, the higher the pH. There's a proportional relationship between bicarb and pH. Okay, so as bicarb rises, the pH will rise. As the bicarb lowers, the pH will lower. There's a delicate balance between the 7.35 and the 7.45 that the body has to maintain. You can see on the left is the acids and on the right are the bases. So there's a 20-to-1 balance to keep that pH in normal ratio. You have to have 20 bicarbs, or kidney function, to maintain a 1 CO2 ratio. Okay, so it takes 20 bicarbs to 1 CO2 to maintain a normal ratio. Kidney control of the bicarb is a look at your metabolic function, and the CO2 is an indication of how well you're ventilating. Okay, not oxygenating, but ventilating. We're going to get into that difference here in a little bit. So remember that. The ratio is 20 to 1. 20 bicarbs to 1 CO2 to keep the pH in normal range. Okay, so why do we use a ABG? Why not just look at a venous blood gas or a venous draw? Why does it have to come from an artery? Well, that gives us a good indication of what our ventilation status is. Okay, so that's one thing we're going to look at as a measure of the respiratory function. It gives us the values of pH, PaCO2, and PaO2. Okay, so those things, the PaO2 doesn't have anything to do with the pH. It doesn't have anything to do with the acid-base balance, but it does tell us their oxygenation status. Okay, so it's a measure of your respiratory function. It helps us guide our treatment changes. So if we have a metabolic problem, we know we have to work with the kidneys. If we have a ventilation problem, we have to work on the lungs. If we have an oxygenation problem, we have to work on the lungs. So we have to monitor our acid-base balance, treat it, and then look at our respiratory and metabolic functions. Okay, let's start with the components of the blood gas. There's 4 numbers in every blood gas, and they're always going to be in this order. So I want you to write this down. pH always comes first, followed by the PaCO2, followed by the PaO2, followed by the bicarb. Sorry. So you're going to have pH, PaCO2, PaO2, and bicarb. They will always, always, always be in that order, no matter if you go to Texas, California, New York, Maine, Michigan, no matter where you go, every blood gas you look at will be in that order. pH, PaCO2, PaO2, and bicarb. So get used to seeing them in that order, because most places will not write pH is 7.42. Bicarb, this, they won't write them out for you. They'll always just maintain them in that same order. Okay, so we're going to start with pH. The pH is calculated by the Henderson-Hasselbalch equation, which I have on the next slide. You can take a look at it. I won't require you to know it. I just want you to know that if on an exam, I know in your RRT there's a question about that, about the Henderson-Hasselbalch equation. The gist of it is that there is a ratio between the bicarb and the carbamino acids. Like we talked before, that ratio should be 20 to 1. You should have a 20 bicarb to a 1 PaCO2, or the carbamino acid. So when that ratio changes, the pH will also change. When the bicarb increases to 25, so now you have a 25 to 1 ratio, the pH will increase. There's a proportional relationship between pH and bicarb. Okay, and when the ratio decreases, maybe let's say it's 15 to 1, the pH will decrease. So we're going to break apart all the numbers of the ABGs so you can understand why they are what they are. So let's just take a look at Henderson-Hasselbalch equation. It gives you a good equation here, and what it's saying that is if you hyperventilate, your CO2 will drop. If you hypoventilate, your CO2 will increase. With those changes in the CO2, your pH will increase or decrease accordingly. Okay, remember there's an inverse proportional relationship between PaCO2 and pH. As your PaCO2 increases, your pH will drop. As your CO2 drops, your pH will increase. With bicarb, there's a proportional relationship. As your bicarb increases, so will your pH. As your bicarb decreases, your pH will decrease. All right, we looked at pH. The normal for pH is 7.35 to 7.45. If we move on to PaCO2, it's a measurement of CO2 eliminated by the lungs. So it's inversely proportional to pH. If you're breathing off too much CO2, you're breathing too fast, it drops your CO2, and then it raises your pH to an alkalotic level. If you hold on to too much CO2, you retain it, causes your pH to drop. Normal value for PaCO2 is 35 to 45. Okay, so pH is 7.35 to 7.45. PaCO2 is 35 to 45. We'll move on to our next component. Remember, it's pH, PaCO2, PaO2, and bicarb. So PaO2 is the measurement of the partial pressure of oxygen dissolved in blood. This is not a measurement of ventilation. CO2 is a measurement of your ventilation. PaO2 is a measurement of your oxygenation. So a normal oxygen level in your blood should be 80 to 100. Anything less is considered hypoxic. Then we're going to separate it into 3 hypoxic ranges. Mild hypoxia is 60 to 80, moderate hypoxia is 40 to 60, and severe hypoxia is less than 40. This is just a good visual of what your PaO2, your P big AO2 from your alveolar level, how it crosses the AC membrane, gets to your bloodstream, and how much oxygen is in your arterial blood. So P little AO2 is your arterial blood. P big AO2 is your alveolar blood. On this slide, you'll see P big AO2 is around 100. Your PVO2, which is your venous blood, is about 40 because that's what's left over after it's dropped off at the tissues. It's headed back to the heart to pick up more. Your PaO2 is what's in your arterial level. That's what's getting dropped off at your tissues. That should be 80 to 100. On this slide, it shows it's 95. All right, so we had pH, PaCO2, PaO2, and now we have bicarb. Normal bicarb is 22 to 26. That's a metabolic measurement. So we've looked at your pH, we looked at your ventilation, oxygenation, now we look at metabolic status. Controlled by the kidneys. It's slow to act, takes a day or two to adjust, but it will adjust at some point. But normal is 22 to 26. Has a proportional relationship to pH. So as your bicarb increases, your pH will increase. As your bicarb decreases, so will your pH. I'll let you study this on your own time. It's a good example of how our body maintains the normal pH and what happens if it's disturbed. So I'll let you look at that at a later time. Okay, base excess. BE is base excess, an indication of how much extra base is available in the body. It's a calculated number. Not very many labs use it anymore, but you may see a therapist or two once in a while that uses it. But it's a measurement of how much alkaline is in the blood. Normal value is -2 to +2. If the base excess is 0, then the amount of alkaline in the blood is just right. If the base excess is greater than 10, then there's too much alkaline in the blood, or if it's -10, there's not enough in the blood. It's the same measurement. It goes the same direction as your bicarb. So if your base excess is high, your pH will be high. If your base excess is low, your pH will be low. Okay? All right. Another component you may or may not see on a blood gas, it kind of depends on the lab, but I just wanted to mention it in case you see it. Some labs do put in an SpO2 value. You may hear it called SaO2, SATs, oxygen check, oximetry, whatever, but typically we'll call it SpO2. Normal value is 90 to 100. Okay, that's what we get off the oximetry device or the oximeter. So it's not a bad idea to check an oximeter as you are drawing your blood gas. That way you can determine if it's a venous blood sample or if it's actually arterial blood. The arterial blood will match your SpO2. All right, so let's review here quick. If you want to write down these numbers. What's a normal value for pH? 7.35 to 7.45. PaCO2, 35 to 45. PaO2 is 80 to 100, knowing there's 3 hypoxic ranges less than 80. Bicarb is 22 to 26. Base excess is -2 to +2, and your SpO2 is 90 to 100. All right, so let's start looking at naming our blood gas. Okay, so we're going to name it in 3 parts plus an oxygenation part. Okay, so we're going to name it acute, partially compensated, or chronic, or compensated. Okay, that will be the first name you give it. Second name will be metabolic or respiratory. Third name will be acidosis or alkalosis. And then you'll separately evaluate the oxygenation status. So you might say it's chronic respiratory alkalosis with moderate hypoxia. That's why I want every one of them named. Or you might say partially compensated metabolic acidosis with mild hypoxia. Okay, so they'll have 4 names to them. Let's look at acute metabolic acidosis. Right away, you should be thinking this is a kidney problem. Okay, I may not have much involvement with the kidney problem, but you need to be able to adjust your therapy or talk to the nurses, or when you give them the results, say, hey, this patient is in acute metabolic acidosis. We need to look at their bicarb. Is there anything we can do for them? Whatever. Okay, so signs and symptoms are listed there. I do want to talk a little bit about Kussmaul's breathing and what it does for metabolic acidosis. Kussmaul's breathing is only found in diabetic ketoacidosis. So if you have a patient who is in a diabetic crisis, they may hyperventilate. They would do the fast and deep breaths. Fast and deep is Kussmaul's. The reason the patient in diabetic ketoacidosis does the Kussmaul's breathing is because they are trying to adjust their PaCO2 to fix the pH. With a diabetic ketoacidosis, you may see a 7.1, a CO2 of 20, and a bicarb of 6. Okay, diabetic ketoacidosis is always going to be partially compensated metabolic acidosis. The rest of the acute metabolic acidosis, you will not see the Kussmaul's breathing. Okay, so the goal of Kussmaul's breathing is to adjust the pH to get it up towards the normal value. Okay, let's look at another number for, or another arterial blood gas for acute metabolic acidosis. Let's say they've had diarrhea for the last day and their body just isn't producing enough bicarb. So you might see 7.2, PaCO2 is normal. There is no ventilation problem unless it's diabetic, but we're not talking about diabetic right now. So 7.2, 35, no reason to suspect an oxygenation problem. They don't have any underlying diseases. So 80, and then a bicarb of 18. Okay, so we have 7.2, 40, 80, and 18. All right, let's move on to acute metabolic alkalosis. Knowing right off the top of your head it's acute, so the body hasn't recognized there's a problem yet. No treatment has been given. This just is an acute problem. It's kidney related because we see metabolic, and the pH is going to be high as well as their bicarb. Okay, can be caused by the things listed there. The kidneys have just shut down and are producing too much bicarb or retaining too much bicarb. Maybe they're dehydrated and holding on to their bicarb. Signs and symptoms are listed there. And treatment, we're going to treat the underlying cause. Okay. An acute metabolic alkalosis number would be 7.5, 40, 90, and 30. Okay, so we have no respiratory involvement in this one. It's a renal problem only, or a metabolic problem only. All right, acute respiratory acidosis. Now this is something we can fix. Okay, so right away we know it's a CO2 problem. It's a ventilation problem. Not an oxygenation problem necessarily, but a ventilation problem. Okay, so they're holding on to too much CO2. Maybe they've had too many narcotics post-operatively and they've slowed their breathing down. Maybe they've had a chest or head trauma and they're not able to ventilate appropriately. They may have increased dead space and they're holding on to too much CO2. They might have a neurological disorder or they have inadequate chest expansion or inadequate diaphragmatic movement, or there's an airway obstruction present. Okay, so they have too much CO2 in their blood. Things to look at for acute respiratory acidosis. The big one is going to be decreased level of consciousness. Okay, and then we have a chronic respiratory acidosis. These are some signs and symptoms you might see with chronic respiratory acidosis. Maybe they have emphysema or something like that. Okay, treatment. If it's chronic, we don't want to treat it because the body has compensated. So if you see a blood gas, we'll talk about compensation here in a little bit actually. Let's do acute. If we have an acute respiratory acidosis, let's say it's 7.2, CO2 of 70, PaO2 of 70, and a bicarb of 24. Okay, so that high CO2 is causing the pH to be low. So we need to ventilate for them. We don't want to just give them oxygen. That's not going to fix the ventilation problem. We need to breathe for them. I've told students in the past, if you have an acute respiratory acidosis and you say put them on oxygen, I will fail you. I'll fail you on that quiz because you cannot treat somebody with respiratory acidosis by giving them oxygen alone. You have to give them You have to breathe for them. You have to ventilate for them because they are not ventilating well on their own. All right, acute respiratory alkalosis. Now we have a patient who is eliminating too much CO2. They might be anxious, they're hyperventilating. They might be hypoxic. They're trying to increase their respiratory rate to try to get more oxygen to their blood. They might have some metabolic problems. They might have a ventilation problem. Maybe the therapist who set up the ventilator set the rate too high. Maybe they have CNS stimulation, whatever. With anxiety, I want you to note that you will not have any hypoxia with anxiety. Okay, so you might see a blood gas at 7.5, 20, 100, and 24. If you have a hypoxic blood gas, you will see 7.5, 20, 40, and 24. Okay, so remember in anxiety, you do not have a hypoxic problem. Only with a hypoxic blood gas will you see a high respiratory rate and a low CO2. Okay, signs and symptoms, you can look at those. Treatment. We want to watch for respiratory failure because their muscles are going to get tired from breathing so fast. We somehow need to get their respiratory rate decreased. Okay, so we might, if they're having an anxiety attack, we might do focused breathing, anti-anxiety medications, or breathe in a bag. If they have a hypoxic blood gas, we want to put them on oxygen and just watch them for a little bit. We maybe don't want to put them on a vent right away or ventilate for them. We want to maybe do some focused breathing, but definitely put them on some oxygen. No need for anti-anxiety medications for a hypoxic patient. That's only if they're hyperventilating due to anxiety. Okay, so we've gone through the four major types of blood gases. We had acute metabolic acidosis, acute metabolic alkalosis, acute respiratory acidosis, and acute respiratory alkalosis. Okay, so what you've noticed is that in a metabolic problem, the bicarb will be affected. If it's a respiratory problem, the PaCO2 will be affected. Remember, that's a ventilation problem, not an oxygenation problem. We will assess these blood gases in separate parts. We'll look at the acid-base imbalance and then the hypoxia state separately. Okay, so we want to look at, does the pH go the same direction or have a relationship with the pH? Is the PaCO2 high and the pH is low? Is the PaCO2 low and the pH is high? We need to look at that inverse relationship and see if those match. That will be our first step to interpreting a blood gas. Does the bicarb match the pH? It's a proportional relationship. So bicarb rises and the pH will rise. As the bicarb lowers, the pH will lower. Okay, so let's start with naming the pH. it's less than 7.35, we will name it an acidotic name. Okay? If it's greater than 7.45, we'll name it alkalosis. Then we're going to decide if it's a metabolic or a respiratory problem. So which one, the bicarb or the PaCO2, is off in causing a pH problem? Okay, so that's the first relationship we want to look at. Okay, so after we've named it, we did our initial look at it, now we're going to take it a step deeper. And if you need to stop here and kind of get your thoughts in order, review your PowerPoint, make sure you know the normals, make sure you can interpret a basic acute problem. Okay, so stop here and go back and look at your notes and make sure you can do an acute problem. Okay, next we're going to move to a compensation problem, or how the body compensates. Compensation means that the body has internally fixed it. So if I say what's the compensatory mechanism to an acute metabolic problem, you would say the lungs. Okay, the lungs are trying to compensate for a kidney problem that's not being fixed by the body. If I say what's the treatment for a metabolic problem, you would say either flush the bicarb out or give them bicarb. Okay, so treatment is an external thing that therapist or nurses or any clinician tries to do for the patient. They catch it in the initial state or the acute state, and then they try to fix it. Okay? If we don't catch it in the acute stage, say maybe the patient doesn't come into the hospital or they come in too late, then the body internally fixes it because the body does not like to have an imbalance with their pH. They like to maintain that pH at 7.35 to 7.45. Okay, so to compensate for that imbalance, if we don't step in and treat it in the acute stage, then the body will compensate or fix it internally. Okay. All right, the goal of compensation is to maintain a normal pH. If it's a problem with the lungs, then the kidneys will compensate it after a while. They won't do it initially because usually the patient has so many signs and symptoms, they come in to the hospital and say, I need help. But if they don't, then we'll get to compensation. All right, these are the steps to compensation. If the compensation occurs fully, the pH returns to normal. If the compensating organ can't work hard enough to compensate, the pH will still be abnormal. pH will now have a value of 7.4 instead of a range of 7.35 to 7.45. So if you see an ABG where the pH is normal, you want to start looking at compensation. Okay, you'll look at the other two values, meaning the PaCO2 and the bicarb. For the rest of this PowerPoint, we're not going to talk about oxygenation so much because that's a separate evaluation of the blood gas. Now we are just focused on the bicarb and the PaCO2. So we'll use the same rules as with regular interpretation. We'll identify if each value is acidic or alkaline. So if you have a high PaCO2, you should see a low pH. Or if you have a high bicarb, you should see a higher pH. So we'll use the same rules. We'll match like abnormalities to interpret the ABG, knowing that now our 7.4 is going to be our perfect number. If it's less than 7.4, but it's 7.35 to 7.4, we'll have an acidotic number. If it's 7.4 to 7.45, we'll have an alkalotic number. Look at the value that doesn't match. Okay, so if it's abnormal, the organ is trying to compensate. Relook at the pH using the range of 7.35 to 7.45. If it's in normal range, complete compensation has occurred, meaning the pH, if the pH is back in the normal range. If it's out of the normal range, then only partial compensation has occurred. If it's unmatched, you have no compensation or the acute. So now we're going to add to it. You have either acute or uncompensated. Those two terms mean the same thing. You might have partially compensated, or you'll have compensated or chronic. Those two terms mean the same thing, compensated or chronic. Okay, so our first step is the pH in range or out of range. So we're going to look at compensation, so we're going to say it's in range. Are the lungs or kidneys helping keeping it in the normal range? Which one is helping more? And remember, there's a difference between compensation and treat. Hints to compensation. All right, let's start at the bottom. Let's look at an acute problem. This is day 1. The patient has an initial injury or insult to the body. That's an acute problem. So if we start down there at the bottom, the initial blood gas, let's use the ones on the left side for right now. We have an acute problem of 7.32, a PaCO2 of 60, a PaO2 of 70, and a bicarb of 24. Okay, so this is day 1 of the problem. It's an acute respiratory acidosis. Okay, acute respiratory acidosis. Now the patient didn't come in, didn't want any help. Maybe they had pneumonia, maybe they had an emphysema problem, whatever. But they had an acute problem. Day 2, we draw blood gas on them for whatever reason. Patient still won't come in, but we've drawn a blood gas on him. Now look what's happened to the bicarb. Okay, we still have a 60 PaCO2. The pH has come up a little bit, but not because of the CO2, but because the bicarb has helped. So the bicarb increased, the pH increased. Okay, so that's day 2. Now look at day 3. We have a perfectly compensated pH. It's back to the 7.5. It's between 7.5 and 7.4. CO2 has not budged. The body said, I like a CO2 of 60. I'm going to keep it there. I can't fix it. My lungs are damaged. I can't fix it. I'm not going to do anything. So the bicarb now is up to 32. It said, the kidney said, well, if you're not going to fix it, I hate having a pH of acidic number, so I'm going to jump in and fix it. So the bicarb jumped up to bring the pH back to the normal value. That's why we have an improportional or inversely proportional ratio and a proportional ratio, because if they were both the same, we'd never have any compensation. Okay, so that's why those values act as they do. So this is a perfect example of a day 1 or an acute situation. You have a pH that's abnormal, and then one other value, either the PaCO2 or the bicarb is abnormal. Okay, so in our case, the PaCO2 is normal, but the bicarb remained normal. PaCO2 is abnormal, bicarb is normal. So that's an acute problem. Day 2, we had partial compensation. All 3 values are abnormal. pH was abnormal, PaCO2 was abnormal, and the bicarb was abnormal. Day 3, the body said, I've got to fix this. So I'm going to bump up my pH by bumping up my bicarb. Okay, so the pH remains normal, PaCO2 is abnormal, and the bicarb is abnormal. That's when you know you have full compensation. So those are the 3 rules to compensation. Uncompensated or acute, partial compensation, and then fully compensated or chronic. You never want to treat a chronic problem. Okay, the body has adjusted itself. Say 2 weeks later, this gentleman comes in, we draw blood gas, this is what it looks like. We never want to treat a fully compensated or a chronic blood gas. The only time we might do that is to put them on a little bit of oxygen, but that's it. Everything else we want to leave the same. Okay, so let's look at a metabolic problem with compensation. We have 7.49. Let's go down to the bottom again, down to the acute problem. This is day 1. 7.49, 38, 80, and 30. So it's an acute metabolic alkalosis. We followed our rules. We have an abnormal pH, and our bicarb is abnormal, but the PaCO2 stayed the same. It hasn't recognized there's a problem. Okay, day 2, the body says, ooh, I really don't like having an alkalotic pH. But the kidneys aren't going to move. See, the bicarb has stayed at 30, but now what has changed? Right, the PaCO2 has increased, bringing it from a 7.49 down to a 7.47. We have inversely proportional PaCO2. Okay, so the CO2 came up, pH came down. Now let's look at day 3. Bicarb has stayed the same, but now look at the PaCO2 is up to 50, bringing the pH back to normal. Okay, so it brought it from a 7.49 down to a 7.44. Okay, so now it's fully compensated. I'll let you study that for a little bit. I'm going to move on, but you can come back to this slide at any time. All right, so let's try this one. 7.38. We're less than the 7.4, but we're still in the range of normal, 7.35 to 7.4. Our CO2 is high, dropping that to the acidic number. Okay, so it's got to be a respiratory. Those two match, the 56 and the 7.38. Bicarb is high, bringing it down to a normal value, because originally we probably had, bringing it up to a normal value. We originally probably had 7.31, 56, and 24. So the pH rose because the bicarb rose. The 56 didn't move from day 1 to day 3, so the bicarb had to kick in. So this would be a perfect example of a chronic respiratory acidosis. Okay, we're going to evaluate the PA2 in a separate range. We already talked about that. All right, and the rest of these I've just given you some to try. There's a table you can look at. And you can email me the answers to these and I'll sure give you some feedback.